Everyone, and our lecturer today is Dr. Manuel Vallesteros from Philippines, and Noel will be speaking to us on oral health and hygiene care in elderly patients. Pleased to note on the panel we have Professor Callum Durwood from Cambodia and Dr. Jacob Johns from Malaysia. Noel, thank you for giving up your time, and thank you for agreeing to give this lecture, and we look forward to hearing it from you now.
Thank you, Professor Rahman. Okay, let me share my screen. Okay, good day, everybody. I'm Dr. Noel from the Philippines. First of all, I would like to thank Global Child Dental Fund for this opportunity to speak on special care dentistry. Today, I've been tasked to give a talk on oral health care for the elderly. Actually, I'm a pediatric dentist, and you must be wondering why I'm giving a lecture on geriatric dentistry. My mom passed away 4 years ago at the age of 90. She was suffering from Parkinson's disease and later developed dementia, and I took care of her. And I saw the rapid decline of her health, including her problems on oral health. And I realized that a lot of her oral health problems were preventable had I known better. Okay, I'm not very proud of what is happening in the Philippines. This picture was posted on Facebook last July. It's a dental mission program that quite violated all the safety protocols for the pandemic. Now, most of our programs for the elderly are still the traditional unsafe dental missions, consisting of dental extractions and construction of free dentures. The aging population certainly deserve better than this. So I do hope that this short lecture will inspire students to pursue a more compassionate dental practice. Now, dentistry is not just about fixing teeth, it's about treating a person as a whole, oral health being an essential component of general health. So what are the statistics? There were 703 million people who are over 65. That's 2019. The highest number can be found in Eastern and Southeast Asia at 260 million, and it's expected to grow over 1.5 billion in 2050. Now, oral health among older persons is definitely a neglected field. We do not have sufficient data. In an oral health survey conducted by the FDI, only 44% of the countries responded. In the Philippines, we have no data on oral health status of our senior citizens. The aging population definitely belong to the vulnerable and marginalized groups. Now, what I have learned throughout my years in practice is that oral health is a human right. It is not a privilege of only those who can afford to pay, but also of the poorest of the poor. Oral health is a human right of everybody throughout a person's life cycle. We call it from womb to tomb. In the Philippines, we have the expanded Senior Citizens Act, which grants benefits and special privileges to older persons. Unfortunately, in the Philippines, dental services are not included in our national insurance coverage. That's why there's an urgent need to promote equity, to push for reforms through policies, laws, and regulations that will address the oral health needs of those who need it more. What are some of my realizations? First, aging is universal. No one is exempted. Every individual, family, community, and society will go through the aging process. Aging is inevitable. Despite the advances in science and technology, no one can escape from this, and it cannot be halted. However, it's a normal dynamic process. So normal aging should be differentiated from the disease. So limited mobility and frailty, osteoarthritis, and joint issues are some issues of normal aging, while dementia, Alzheimer's, hypertension, and diabetes are diseases. And we all know that the deteriorating physical and mental capabilities of the aged and the decline of self-care capabilities and the lack of access to quality health care will all result to poor oral health conditions, leading to malnutrition, which may even accelerate the rapid debilitation of overall health, leading to death. We must also fight ageism. It's very harmful as it has a negative impact on the physical, mental, and social well-being of the elderly. In short, we shouldn't even poke fun on growing old as it stigmatizes aging and has a mental impact on the elderly. Now, here is our age classification of senior citizens. But for this lecture, I will be more on the descriptive classification. For the active and capable, they are robust. For the limited activity and capability, they are frail. And those with very limited activity and capability, they are dependent. Problems arise when the elderly become frail and they are more vulnerable to stress-related conditions. So my lecture will focus more on the oral health care for the frail and the dependent. Now, there are different levels of managing the patient, specifically the elderly. You have the mouth level, patient level, family level, and community level. For the patient level, first, we need to assess the patient, prevent and control the disease before we can treat them and maintain the restorations. So first is assess. We need to assess patient capability and identify the risk factors toward oral disease. Actually, when I took care of my mom, that's the time that I really appreciated the definition of health. When I was younger, I thought being healthy was just what? Being able to go to the gym and then jog around. It's more of the physical. But when I took care of my mom and she lost her mental capabilities, so is her social well-being compromised. She couldn't already go to her social functions and not being able to see her friends. That's why healthy is all about being physical, mental, and socially healthy. So first is we assess patient capability, physical, mental, and social. So is my patient active or inactive? Is my patient medically well or is my patient compromised? Mental, is my patient cognitively well or cognitively impaired? Because there are signs of cognitive impairment, like for example, a lot of elderly will even verbalize that they are becoming forgetful. So there's loss of short-term or long-term memory, confusion, impaired judgment, poor motor coordination, and even dysphagia. So when there's cognitive impairment, there's loss of self-care, and then there's the increase for oral disease. That's why we need to target the caregivers to take care of the elderly. Next is social. Is my patient independent or dependent? Because social isolation and loneliness is a growing concern among older people. And a lot of them, because of loneliness and depression, they have already given up. They've already given up living, and they don't even consult the medical professional because of psychological isolation. Worse, a lot of elderly, they go through life-changing health events. Like my mom and my dad, they suffered accident inside the bathroom. They suffer falls. And then oftentimes, a lot of elderly, they get stroke, heart attack, and then they are diagnosed with cancer, Alzheimer's, Parkinson's, dementia. And all of these diseases have a large impact not only on the person, but also for the entire family. So, after assessing patient capability, we identify the risk factors towards oral disease. So these are the following, which I will enumerate later on. And in identifying the risk factors, I will also identify measures to prevent and control the spread of the disease by controlling the risk factors. First and foremost, it's very important what we need to learn is that restorations will not solve the disease. We must first control the disease. Why? During our undergraduates, oftentimes it's so much focus on dental restorations. But we all know that it will not control the disease. We must first control the disease, and then after restoring or rehabilitating, we must also maintain. So this is a classic picture of the oral health of the elderly. So there's root caries, gingival recession, coronal caries, gingivitis. So we first ask the question, why? So it's like a burning house. There are risk factors. You need first to get rid of the risk factors. Control the fire, and before you can build the house, you must first control the fire before you can restore and rehabilitate. So what are the risk factors? Number one, systemic diseases and taking a lot of medications. So a lot of elderly, they suffer from chronic diseases, and in turn, they take a lot of medicines compounded by frailty and dependency. And they lose their senses. That's why they take a lot of medicines. It's very important that we consult the physician and then update the medical history. Because a lot of these drugs can also cause xerostomia. And you know that a lot of elderly, they have this kit, their medicine kit, which contains a lot of maintenance drugs. Number two risk factor is xerostomia or salivary gland hypofunction. We all know that saliva is the natural defense mechanism against cavities. And if they are taking 4 maintenance drugs a day, more or less they have already suffering from dry mouth, which can lead to mucositis, caries, cracked lips, and even fissured tongue. So what are our recommendations? Drink lots of water or sip water regularly all throughout the day, and limit alcohol and sugar-sweetened beverages such as juices, sodas, teas, and teas, juices. And since your saliva is your natural defense mechanism against cavities, sometimes they need adjuncts, such as your calcium and phosphate creams, which will supply the lost calcium and phosphate brought about by xerostomia. Number 3 risk factor is lifestyle. So a lot of elderly, as we all grow old, we get to acquire habits, and most of them are bad. And worse, a lot of our elderly, they become stubborn because they just want to enjoy life. So these are some of the habits that they have acquired: drinking alcohol, smoking, and they just want to enjoy life. They keep on eating even if the food is harmful for their health. So they do not care as long as they enjoy life. That's why they are also stubborn. So the number 4 risk factor is diet. So diet that is very rich in sugar will not only lead to more caries, root caries, coronal caries, but also to obesity, cancer, cardiovascular disease, and diabetes. That's why it's very important that we need to campaign, we need to have advocacies in our respective communities, such as this one, sugar reduction. So we need to campaign. Instead of these processed foods, maybe they go to the market and buy fresh fruits and vegetables. So number 5 risk factor, the lack of oral hygiene. So maybe they need a lot of help because they lose the manual dexterity to brush on their own. So maybe we need to modify their toothbrushes or introduce an electronic toothbrush. And most of the time, they need assistance also. Next is the fluoride toothpaste. And a lot of elderly, because they become high risk to root caries and coronal caries, we might have to prescribe a 5,000 ppm fluoride toothpaste. And then the 7th risk factor, the lack of social support. So is my patient alone and independent, or is she residing with a caregiver, or does she live in a nursing home? So what is quite risky is when they are living alone and they suffer depression and loneliness. Number 8 risk factor is, does my patient have as a dental home? So a dental home is more about a relationship. It's more of regular dental care. So when we talk of dental home, we talk of primary oral health care, services that are essential but continuous. So we need to see them every 3 months. Accessible, most of them are not mobile. So it's either we go for teledentistry, or we might have to go to homes for the elderly, and it is coordinated with the medical, and it is family-centered. We target the caregivers and also the family if they have. So this is what we are campaigning right now, dental home as primary oral health care, that every community health center must be competent or must be well-equipped to provide primary care for the elderly, or we tap on volunteerism. We might have to adopt homes for the elderly because they cannot go to a health facility. So after preventing control, then we might have to treat the elderly. So a lot of them might have to go, might not just need prevention, but those who are at risk might have to undergo chronic disease management. But for some, palliative care, and for some, we might have to refer them to the experts because they might have to go through a hospital care. Why? Because a lot of elderly, they suffer from secondary coronal caries and failed restorations. And they are prone to root caries. Why? Because of gingival recession and the medications that they are taking, which may produce xerostomia. That's why we are introducing rational treatment planning, because the ideal treatment planning might not be feasible for the elderly, and they might only be possible for the functionally independent. But once the patient becomes frail and functionally dependent, we might have to be more rational in our treatment planning. So what is rational treatment planning? We ask the following questions. What does the patient want? What can the patient tolerate? What is realistic? And what can the patient afford? Because most of them are already retired. And the ideal treatment plan may not be possible because of a lot of behavior problems, medical problems, budget constraints. And when we go to elderly homes, there are limitations in technology, time constraints such as life expectancy and tolerance threshold. And we need to also respect patient autonomy. Like some of them might not be ready for invasive treatment. That's why rational treatment planning is not about achieving the perfect result. Oftentimes, we just want to control the disease, the spread of the disease, and improve quality of life, specifically preventing pain and spread of infection. That's why when treating elderly, we need to give training on minimal intervention and minimally invasive dentistry. So the ICCMS has non-invasive techniques. So you have your primary prevention, your non-operative care, and your tooth-preserving operative care. So this is the non-operative care. We do prophylaxis, apply fluoride varnish, prescribe high fluoride toothpaste, and we might have to do glass ionomers specifically on root surfaces and the silver diamine fluoride, which are all non-invasive. Now, so for the tooth-preserving operative care, we might have to do indirect pulp capping using the glass ionomers, and of course your ART fillings, and in the United States they call it IPR. So these are non-invasive, atraumatic, non-technology dependent, and they are more affordable, which is quite ideal for the elderly. So this is from the slides of Professor Ian Ngo, application of 2.26 fluoride varnish. And the silver diamine fluoride, the fluoride varnish is for coronal caries, but for the dentine caries, we do the 38% silver diamine fluoride if we want to control the spread of infection. And this has been supported by a lot of studies, and there are still ongoing studies on its effectiveness. And of course, for self-care is very important. So there are so many products at the commercially available. And glass ionomers, these are fillings that can really control the spread of the disease because they contain fluoride, which will arrest caries, and there are also reservoir of fluoride where they will accept and absorb fluoride from other products, such as your toothpaste and mouthwashes. Again, this is lifted from Dr. Brostek's cases with your GIs on your root surfaces and your cervical lesions, and which is quite very common among the elderly. Now, a lot of restorations cannot be restored ideally. So oftentimes, because of medical problems, we cannot put crowns, we cannot put the ideal restorations. So we can put the glass ionomers. Personally, I find the flowable glass ionomers very, very convenient, specifically for patients with dementia. I placed one on my mom's lesions, cavities. Next, after treatment, we maintain. So maintenance is very important. So regularly, we put fluoride varnish. Monitor the use of fluoride toothpaste. You might have to prescribe calcium phosphates or saliva substitutes, and then radiographs if possible. So remember, people don't care how much you know until they know how much you care. So that's what compassionate dentistry is all about. That's why we are initiating right now a healthy aging protocol. So oral health in all policies. And prevention starts at age 50 because it's the youth of old age. When I turned 50, that's the time that I took care of my parents, and I realized that as early as age 50, I already have class 5 lesions and even gingival recessions. So I need to prepare myself and my patients for the aging process. But most of our patients at 50, they are in denial. So what he's saying, maybe give them time to accept that, yes, we are all growing old. And preventive care, while the patient is still relatively healthy, that they can go back to their dentist. Prepare the recently old for their advancing age, because what we do now has an impact later on. So Once there are already class 5 lesions, root exposure, try to cover them up with your glass ionomers because they are very susceptible to spread. Why? Because the exposed dentinal tubules, which will result to cervical sensitivity, and they are more prone to acids, and they are also plaque trap. And then I keep on telling my, when I do lectures for the elderly, brush gently. Why? A lot of elderly, they brush vigorously with the thought that when they brush vigorously, they are cleaning the teeth better, which is a misconception. So healthy lifestyle begins at 50. So ideally, when they reach 80, they still have 20 teeth, a dentition that is free from active caries, so on and so forth. That all restorations are functional and they can eat well. And if we have baby book, I want to introduce the healthy aging diary because most of them become forgetful. This is also for the caregivers. So they have a checklist, which is the following. So preventive non-invasive measures done every 3 to 6 months. So it's also very important that we spread this specifically for the younger generation because all of us will go through this stage in life. So this is an example of a dental home for the elderly. So this is a group. This is an adopted community. Most of them are already frail and dependent. So it is coordinated with a medical organization in the Philippines. So they do prophylaxis for the elderly who can tolerate it. But we tried dental chairs, but most of them are wobbly. So we improvised them. We introduced the dental beds, which are more stable. So was during the pandemic. They still undergo care, checkups, and non-invasive treatment. And never forget motivating caregivers. So right now we have installed television sets so we can monitor them and talk to them through the television. And then advocacy is very important, like brushing. We have this Happy Brushing to You anthem. And then also we ask the visitors not to bring sugary beverages and foods, just healthy foods. So at this point, we also have introduced teleoral health. And this is very important also for the elderly because they cannot go out of their homes. So to conclude my lecture, I will lift this from the FDI World Dental Federation, the 8 core pillars to improve the oral health of the older adults. So oral care should always be integrated with general care. So we encourage our government to integrate oral health in all policies. K-dramas are very popular in the Philippines, and this is the recent K-drama that we have seen that specifically for the oral health to enjoy life, they should be enjoying all the foods that they should be eating. So eating well is very important. And then promote oral health through life course. That's why there are stages, but for the elderly, prevention starts at age 50, and all of our actions should be evidence-based. And then financial barriers, so we intend to include this in our insurance policies. And physical barriers, because they are no longer mobile. So we have mobile oral healthcare services. And the pandemic has also given us the opportunity to really use teledentistry. So this is an example of one of our mobile dental buses. and then provide appropriate oral health care, specifically the use of minimal invasive dentistry, and mobilize all stakeholders. So it's not just dentists doing oral care, but we need the help of everybody, including the medical organizations, the nurses, the midwives, the nurses, and globally, we need the help of everybody, the research, public health professionals, media, down to the smallest unit, the patients and their families. And we want to learn from best practices from other countries. That's why collect and share best practices are very important. Sharing is caring. So to conclude, we are now in the Philippines, we are really pushing the universal healthcare. It's already a law, but we need to include oral health in our universal healthcare. Okay, so it's really a struggle in the Philippines. So I'm sure a lot of students are watching right now. I know that all students are vying for the highest honors, but after you graduate, I would like to say that to care for those who once cared for us is one of the highest honors. And with that, thank you very much for your time, and I hope we inspired you that after you graduate, you take time to take care of the elderly. Maraming salamat po and thank you.
Dr. Noel, thank you so much. That was excellent, really excellent. So I'm a pediatric dentist like yourselves, and I couldn't have done such a good lecture. So thank you for that contribution. We're going to have a short question and answer. I'm going to ask Callum if he would like to kick off. Any comments or questions?
Sure, I really enjoyed your presentation, Dr. Noel. Thank you very much. I was thinking, do you think that dental students are exposed enough to elderly patients during their training? Because I think if you're not exposed, then you're not comfortable sometimes treating groups of patients like the elderly. So what's your opinion about that?
Yes, Professor Calum, I really do agree. Here in the Philippines, the students are more into the technical, and their exposure is just what? Their training is more tooth-centered, and when they get to face elderly patients, they do not know what to do. And because basically there's really lack of training and lack of exposure in treating elderly, specifically the frail and the dependent. In the Philippines, they just they recruit patients just to fulfill the requirements for complete dentures and removable partial dentures. But then again, that's very technical and tooth-centered. That's why part also of our campaign and advocacy is to reach out to the universities on how we can really be more effective in addressing the marginalized, specifically the elderly, which starts during the undergraduate training. So exposure is very important, really. It's so important. Yes, I do agree.
Yes, and all of our Asian countries have all got a growing number of elderly, and it's going to be much more of a problem in the future. And we have to be able to provide services for that group.
Yes, I do agree. Yes. We need to train the next we need to mold the next generation and prepare them. That's why we need to reach out to the students. Yes, I do agree.
Thank you. Any follow-up comments, Callum, or any other questions?
Perhaps you could comment on the diets of elderly people. Do you think that their diets change as they grow older? And what sort of changes affect their oral health, do you think?
Well, in my experience, usually good diet really begins during your younger years, and then when you grow old, you develop this healthy lifestyle. But I've seen a lot of elderly, they just want to enjoy life and they just take in whatever they want, even if it's not healthy for their teeth. Like, well, here in the Philippines, they love drinking alcohol, and we love all of this high cholesterol foods, meat, and all of this fatty diet, and it's very common here in the Philippines. So I really feel it's really cultural. That's why we really need more. We really need to be more active. It's all fat and cholesterol. Really,
And
really
sugar
to
too, I
educate.
think.
Yes,
And sugar.
Filipinos really love sugar. That's why we have one of the highest caries prevalence in the world.
Good, yeah.
Yeah, it's really
Yeah.
bad.
Okay.
Lifestyle, yeah.
Thank you. Jacob, any comments or questions?
Thank you, Prof. Rahman. Thank you, Dr. Noel, for the presentation. Looks like I'm outnumbered here. 3 pediatric dentists and 1 prosthodontist. The closest to the geriatric is the minority.
Yes.
Very interesting presentation, Dr. Noel. Thank you. Just 2 comments from what Prof. Callum mentioned just now. One, the institutions, probably we have to look into universities without walls, okay, because we are very focused on all our teaching in the clinical setup, whereas now we have to start thinking about managing community in the community. I suppose that's something that we have to really look into, because especially like you said just now, in Eastern and Southeast Asia, the number of elderly is really growing up, and we have not equipped, our students to the level that they can take care of those who are functionally dependent on us. That was one thing. And then probably the diet, maybe I am a culprit. I think the teeth is the key. Once you lose your teeth, once you have lesser occluding components, then they start changing their diet to be able to just eat and swallow it rather than chew and appreciate those kind of food. So that is when probably they will try to change the diet to the less fibrous and more starchy kind of food. Dr. Noel, I just want to ask you, you started off by showing your the slide where you said it is not, we are not proud of the fact that treatment is being provided. I think again it is a global, or rather even in this region, it is something that it happens very often. Now, one of the reasons will be probably because we do not have proper policies in place where we have our dental practitioners going out and providing that care because of all the legal issues as well as regulations. How do you think we can overcome this in the in the future, where we can have some understanding from our policymakers about the importance of providing these sort of cares by the professionals rather than
Yes.
in a very unhygienic method?
Yes, Professor Jacob. Actually, well, first of all, I'm already a policymaker in the Philippines. I've just been appointed as the chief of the Oral Health Division of the Department of Health 2 months ago. So right now we're working on policies, and we really need, one of my colleagues at the Ministry of Health, at the Department of Health, told me, Noel, what is lacking among dentists is that you are so focused on the clinical, and we are less on the advocacy, on the oral health promotion side. It seems that, well, at least in the Philippines, we are our training is just focused on the clinical and less on being an advocate, a mediator, an enabler. So we really need also to train our students to really go out and be advocates. Okay, so in my case, we really need to connect with the politicians. We need, I'm telling all dentists to go out of their clinics and do oral health promotion, specifically among local government officials and even the national officials. We need to have champions inside the government. We need to identify advocates, champions among our congressmen and also among the Senate, and then convince them how oral health is important to general health. And that will also start with policies. Right now in the Philippines, we are formulating a national oral health policy that is aligned with the universal health care. So it all starts with policy, but again, the next step is the implementation, which is oftentimes a problem, specifically here in the Philippines. So it's a really deep problem, it's a huge problem, but hopefully if we can really inspire others and go beyond the clinical, I'm very positive that we can institute changes step by step.
Good, that's really helpful. No, let me just ask, there's two questions I would like to ask is, traditionally when we saw seniors and healthcare for an older population, we always thought of dentures. We thought of dentures or extractions, and that was the common care that was perceived for this population. But we have a group of increasingly dentate seniors with complex restorations. So they could have implants, they could have lots of things in their mouths, which it makes care very much more difficult. And I just wondered whether you would reflect on that, of how the changing nature of oral health for seniors is really complicating this situation.
Okay. Well, here in the Philippines, all of these complex restorations, implants are really very, very expensive. That even it's only the rich can really afford it. But for the increasingly dentate people, hopefully, if the universal health coverage will cover oral health care, hopefully we might be able to address these issues and get funding for the other oral health problems of the elderly. But at this point, we are really prioritizing the primary oral health care. Hopefully we'll get there, but at this point it's really expensive, and,
Yeah.
and most of them have medical problems.
I understand. No, I empathize with what you're saying. So there's an age-old debate in dentistry about specialists, and there you are as a pediatric dentist talking about care of the elderly. But do you think that with the issue that Callum has raised with a growing number of seniors, the fact that these seniors have more complex problems, plus the fact that we have this population living older and having comorbidities, do you see that we will have a specialty of geriodontology? And is that something you would welcome?
Yes, Professor. Very much welcome here in the Philippines, geriatric dentistry, because right now there are no geriatric dentists in our country.
Yeah.
And that's why I feel so bad, because the all elderly population do not receive the proper oral health care that they really deserve. So
Yeah.
I really do welcome. In fact, I've even talked to the Philippine Dental Association, the mother country organization, that maybe we can start promoting a geriatric dentistry in the Philippines so that the awareness will spread that, hey, our country needs specialists. We need geriatric dentists to provide tertiary care for these population groups.
Gosh, okay, that's very interesting. It's I think that's the case. I think there's a growing issue, and it's a logical argument to say we need specialists in this area. But so that's really helpful. I'm going to turn finally to Callum and Jacob. Is there any final comments or questions you would like to ask?
Just to add to that last point about the need for specialists in special needs dentistry and geriatric dentistry, but there's also a need for others, such as dental therapists, who can go in to places where there are a lot of older people who are dependent, frail, and help them to maintain their oral health, just using simple techniques. I think that's another area that also is needed.
Very good point. Thank you so much. Jacob, is there any final comment you want to make?
Yeah, and to add to that, that would also help in reducing the cost for the service providers. And it is being practiced in a few pockets. I think in Japan, they've already started doing this. So yeah, that is also very, very essential. I think you cannot be depending only on the dentist, but you have to add the auxiliaries, empower the auxiliaries to be able to help out in this service also.
Okay, thank you. It's a very interesting, very good point to end in. Our medical colleagues have general nurses with extended duties. So they learn a particular technique or something, and they have extended duties. We have a large number of dental assistants, and we should be looking at some extended duties that they may want to undertake. So I think that it's a very interesting and fertile debate. And Noel, thank you so much, because you've generated all this thoughts and discussions, and congratulations on your new appointment. We wish you well in the Ministry of Health. Pediatric dentistry still needs you, so we'd like you to keep one foot in the Department of Health and one foot in the pediatric dental world as well. And we look forward to seeing you face to face, hopefully next year. So with that, we want to say thank you, and we'll now wish you well. Okay, goodbye.
Thank you very much. Thank you.
Thanks.